Welcome back, health enthusiasts. Today, we're delving into the fascinating realm of IgA vasculitis, a condition previously known as Henoch-Schönlein purpura. This disorder involves a systemic inflammation of tiny capillaries, triggered by acute perivascular deposition of immunoglobulin A, IgA, and neutrophil activation. The traditional features of IgAV include kidney involvement, arthritis, gastrointestinal, GI, tract involvement, and cutaneous vasculitis, which can happen in flare-ups. In rare cases, there may also be effects on the central nervous system, CNS, or lungs. Different IgA variations may just affect the skin or kidneys. The prevalence of IgAV peaks in children aged 3 to 10 years, with the mean age at presentation being 6 years, but the condition is also seen in adults. More common in boys. Let's explore the etiology of this condition, a complex interplay of genetic, environmental, and antigenic factors. The exact cause of IgAV is not fully understood, but it's believed to be multifactorial. Over 75% of patients report antecedent upper respiratory tract or gastrointestinal infections. Various infectious agents, medications, vaccinations, and environmental exposures have been linked to the development of IgAV. Some infections that may precede IgAV include group streptococcal infection, infectious mononucleosis, subacute bacterial endocarditis, hepatitis, mycoplasma infection, and many others. Notably, COVID-19 has also been identified as a potential trigger. Surprisingly, certain vaccinations have also been associated with IgAV, including the measles, mumps, rubella, MMR, vaccine, hepatitis B, influenza, yellow fever, cholera, typhoid, paratyphoid A and B, and even the COVID-19 vaccine. Beyond infections and vaccinations, environmental exposures can play a role. Factors such as drugs, including adalimumab, ampicillin, erythromycin, foods, horse serum, cold temperatures, insect bites, and even glomerulocystic kidney disease have been linked to IgAV development. IgA vasculitis, or IgAV, demands a thorough physical examination since it can impact various organs. While skin lesions are the most noticeable, manifestations in the kidneys, gastrointestinal system, and joints are quite common. Let's explore each aspect. In the majority of patients, skin lesions serve as the initial sign of IgAV. These can range from erythematous macular lesions to palpable purpura, typically 2 to 10 mm in diameter. The lesions often occur in crops, are symmetrical, and tend to appear in dependent body areas, most frequently in the buttocks, lower limbs. The face, palms, soles, and mucous membranes are usually spared, except in infants. Recurrences can happen in the same sites, and various skin manifestations may occur, including hives, angioedema, and target lesions. In younger children, especially those under 2 years old, the clinical picture may be dominated by edema in the scalp, periorbital area, hands, and feet. This edema, known as acute hemorrhagic edema of infancy, AHEI, rarely occurs after puberty and is correlated with the severity of vasculitis. Rare manifestations include urticaria, petechiae, and necrosis of the earlobe. The most serious complication of IgAV is kidney involvement, occurring in about 50% of older children. However, it's serious in only approximately 10% of patients. Kidney involvement becomes apparent in 80% of patients within the first 4 weeks of illness, and 2 to 5% progress to end-stage kidney disease. Acute glomerular lesions are observed in various forms, and some correlate with renal survival rate, proteinuria, and hypertension. Gastrointestinal manifestations can complicate the initial diagnosis, with abdominal pain and bloody diarrhea preceding the purpuric rash. GI symptoms occur in about 50% of cases and may include colicky abdominal pain, melena, or bloody diarrhea. Intussusception should be suspected in patients with abdominal pain or melena. Arthralgia is a common presenting feature in IgAV, affecting up to 25% of cases. Joints may be swollen and painful, most commonly in the hips, knees, and ankles. Symptoms are transient, with no permanent deformities. Rarely, IgAV may involve the lungs, heart, genitals, or nervous system. Pulmonary hemorrhage, priapism, and orchitis are among the reported manifestations. Neurological symptoms, localized edema, and high serum C3 levels have been correlated with scrotal involvement in male patients. Additionally, rare cases may present with acute pancreatitis or cystic changes in the ovaries. Clinical diagnosis of IgAV is based on typical clinical features. History of any recent illnesses, prescription drugs, or immunizations that may have served as triggers. Urinalysis is usually the only investigation needed in a classic presentation of HSP. If there is hypertension, macroscopic hematuria, or significant proteinuria, also perform the formal urine microscopy and urinary protein creatinine ratio, UPCR. Urea electrolytes, creatinine and albumin. European League Against Rheumatism, EULER, Pediatric Rheumatology International Trial Organization, PRINTO, and Pediatric Rheumatology European Society, PRES, require the presence of palpable purpura or petechiae, with lower limb predominance and without thrombocytopenia or coagulopathy, usually in clusters, along with at least one of the following. Diffuse abdominal pain of acute onset. Any biopsy sample showing leukocytoclastic vasculitis, or proliferative glomerulonephritis with predominant IgA deposition in a kidney biopsy sample in patients with atypical distribution of purpura. Acute arthritis or acute arthralgia in any joint. Kidney involvement, any hematuria or proteinuria, and IgA deposition. No specific laboratory test exists for IgA vasculitis, but general tests can provide valuable insights. Antinuclear antibody, ANA, and rheumatoid factor, RF absent in IgAV. Urinalysis, hematuria is common, and proteinuria may also be present. CBC, leukocytosis with eosinophilia and left shift. Usually normal platelet count HB decrease suggests GI bleeding. ESR, variably elevated. Stool guaiac test, may reveal occult blood. BUN and creatinine may be elevated, indicating decreased kidney function. Electrolytes, generally in the reference range, but vomiting can affect them, e.g., hypokalemia, hypochloremia. Immunoglobulin A, IgA, increased during the acute phase, higher levels associated with kidney involvement. Antistreptolysin O, ASO, elevated. Immunocomplexes of IgG and IgA may be increased. Total IgA levels not very helpful for diagnosis. Galactose-deficient IgA1 levels distinguish IgAV patients with nephritis. Factor XIII activity correlates with severity of abdominal manifestations, aiding in identifying patients with severe gastrointestinal manifestations. No specific laboratory test exists for IgA vasculitis, but general tests can provide valuable insights. Abdominal ultrasonography. When gastrointestinal symptoms are present, abdominal ultrasonography becomes a valuable diagnostic tool. It surpasses barium enema in diagnosing intussusception related to IgA vasculitis. Interestingly, IgA-related intussusception tends to be ilioileal rather than ileocolic. For patients presenting with scrotal edema, imaging becomes crucial. Ultrasonography or technetium radionuclide scanning may be employed to assess the scrotum. Testicular ultrasonography aids in identifying hemorrhage or torsion. Notably, Doppler or radionuclide testicular scan results show normal or increased blood flow in IgA vasculitis, distinguishing it from testicular torsion. Bowel ultrasonographic findings include thickening of the bowel wall, free fluid, and intussusception. While high drops of the gallbladder are rarely observed, kidney involvement may not be evident on ultrasonography initially. Histopathologic features of the skin lesions in IgAV can range from a typical leukocytoclastic vasculitis with or without fibrinoid necrosis to the less specific findings of a lymphohistiocytic paravascular infiltrate with extravasation of erythrocytes. Kidney histology in IgAV varies considerably. In some cases, most glomeruli appear unaffected on light microscopy, only a few show mesangial proliferation. The specific kidney pathologies of IgAV includes diffuse hypercellularity, focal and segmental proliferation, mesangial proliferation, minimal change to severe crescentic glomerulonephritis, segmental sclerosis fibrosis, mononuclear cell infiltration, mesangial, subendothelial, and subepithelial deposits, diffuse glomerular deposits of IgA, C3, fibrin, immunoglobulin G, IgG, properdin, and immunoglobulin M, IgM. IgA deposits in the mesangium. No form of therapy has been found to shorten the duration of IgA vasculitis to any significant degree. Therefore, treatment remains primarily supportive in most cases. Most patients recover quickly, within several weeks, without treatment. Hospital admission and monitoring for complications should be considered, especially for IgAV patients with severe abdominal pain, significant gastrointestinal bleeding, or marked kidney insufficiency. Using acetaminophen, elevation of swollen extremities, eating a bland diet, and adequate hydration are suggested. All unnecessary drugs should be discontinued if a drug-related etiology is suspected. Patients with severe vasculitis and/or IgAV nephritis initiate systemic glucocorticoid therapy. Corticosteroids may be considered in the following situations: persistent nephrotic syndrome, crescents in more than 50% of glomeruli, severe abdominal pain, substantial GI hemorrhage, severe soft tissue edema, severe scrotal edema, neurologic system involvement, intrapulmonary hemorrhage. Let's explore the recommended management strategies and follow-up protocols provided by the Royal Children's Hospital, RCH, Australian guidelines. When a suspected patient's urinalysis and blood pressure are normal or microscopic hematuria with no other features, can discharge the patient with follow-up plan. If the patient has features of unwellness, pain not controlled with simple analgesics, testicular involvement, abdominal pain or peritonism features, respiratory or neurological features, or if the initial urinalysis and blood pressure are abnormal, need to admit patient and need to do additional investigations with specialist referral. Need steroids management. For individuals experiencing mild pain in IgA vasculitis, the approach involves managing subcutaneous edema with bed rest and elevation of the affected area. Additionally, regular use of paracetamol and a short course of nonsteroidal anti-inflammatory drugs, NSAIDs, are recommended to alleviate symptoms. In cases of moderate to severe pain, especially with abdominal and joint involvement, the use of steroids, specifically glucocorticoids, is considered. Administering steroids in children may help reduce the duration of symptoms. Once symptoms have resolved, a careful weaning regimen should be implemented. Follow-up is crucial to monitor for potential complications, particularly renal involvement. Regular reviews by a general practitioner, GP, or pediatrician are recommended. In cases where there is no significant renal involvement, the frequency of reviews can be adjusted. To identify subsequent renal involvement, regular urinalysis is essential. If the initial urinalysis is normal or reveals only microscopic hematuria, the following schedule should be adhered to. Weekly reviews for the first month after disease onset. Fortnightly reviews from weeks 5 to 12. Single reviews at 6 and 12 months. Return to weekly reviews if there is a clinical disease flare or additional signs of renal involvement. If there is no significant renal involvement and normal urinalysis at the 12-month mark, no further follow-up may be required. However, it is essential to remain vigilant and seek medical attention promptly if any concerning signs or symptoms arise. Diving into the prognosis and recovery aspects of IgA vasculitis, when there is no serious renal illness, an HSP episode generally ends after 4 weeks. The rash is frequently the final symptom to go away. Within 72 hours, joint discomfort often goes away on its own. Usually, a simple stomach ache goes away on its own in 24 to 48 hours. Within 4 months of the first manifestation, HSP recurs in 25 to 35% of individuals. Generally speaking, subsequent episodes are linked to milder symptoms that last shorter periods than earlier episodes. 97% of individuals with renal difficulties do so within 6 months, and 90% do so within 2 months of the outset. As we wrap up today's exploration of IgA vasculitis, it's important to remember that while this condition may present challenges, knowledge and understanding are powerful tools in managing it effectively. If you or someone you know is dealing with IgA vasculitis, don't hesitate to reach out to healthcare professionals for guidance and support. Stay informed, stay proactive, and remember, your health journey is unique to you. Thank you for joining me today on this medical exploration. If you found this information valuable, don't forget to hit the like button, share with others who might benefit, and subscribe for more insightful content. Until next time, take care of yourselves, stay curious, and be well.